obvious when defect is too big. But in spontaneous rhinorrhea, sometimes the defect is not very big. And if the CT slices are not very fine, you can easily miss that. So the best modality, if you ask me, the single most important in a routine situation is 3D drive sequence of MRI. Are you getting the MRI on screen, sir?
Yes.
See this. This is 3D drive sequence of MRI. What is the importance in this sequence? In this sequence, the CSF, see the CSF appears bright, the fluid appears very bright in the suppressed background. Entire background is dark, suppressed, even the brain is dark, but the CSF appears bright. And you can see very well in this, what you see? See, this is the olfactory fossa containing the fluid. Can you see? And
Yes.
if I go down, see this is 1.2 mm section. Every time I go by 1.2 mm and see what is there in continuity on the right side. Can you see this olfactory fossa?
Yes.
And this CSF is coming in continuity down in the nose. There cannot be a better depiction of CSF rhinorrhea as compared to this in any given modality. You can see the same high intensity of CSF, the fluid, is coming out of the olfactory fossa in the nasal cavity, in the nasal roof. And you don't need any further investigation or proof to diagnose or label this as a CSF rhinorrhea. It is so obvious. The beauty of this sequence is there is no contrast needed. Nothing. This is a simple sequence of MRI without any contrast, and you can pick up the CSF in continuity so well. But this is not always, something you get. The reason is the CSF is something which is not so obvious at the time of shooting the MRI. At the time of shooting the MRI, if this leak is not there, you may miss this. So at the time of shooting the MRI, there should be an active leak to demonstrate, to pick up this in continuity CSF coming from the brain down in the nose. In situations when, like in situations of intermittent CSF rhinorrhea, patient experience CSF rhinorrhea once in a while, sometimes once in a day, sometimes once in a week, and then it becomes, symptomless. There is no CSF coming out of the nose. And those are more dangerous cases. One can easily overlook, easily ignore. And most of the time, those patients are not treated, not diagnosed properly, so not treated. And ultimately, they present with meningitis. And it is the time of radiology to answer how to pick up those situations. So, audiovisual, can you connect this?
Audio?
Yeah, no, this to this. इससे ये लैपटॉप कर दो ना, कर दोगे? So I'll show you some previous MRI just to touch upon what sequence can pick up the intermittent CSF rhinorrhea. Many a times we get cases where we are in suspicion whether there is CSF or not. Whether it is CSF or sinusitis. It is more important in post-operative situation. Many times we are referred cases from neurosurgeons. They did some skull-base surgery, pituitary surgery, something. And patient has a history of watery discharge. Your routine investigation is not picking up and there is a fear of meningitis. Then what can be done? Are you getting this MRI now, sir?
Yes.
PowerPoint?
Yes.
See this. This particular patient, see there is an obvious defect in the CT scan. And now see what you see, the defect in the CT scan on the same 3D drive MRI, you see the CSF coming down. It is so obvious. So these are the modalities you should use in situations where you are in doubt of a CSF rhinorrhea. Sometimes it is straightforward. This is CT cysternography. For us, it is obsolete now. Again, what information you get from CT cysternography? How CT cysternography is fascinating. You inject an intrathecal dye and you catch or scan the dye coming out of the brain into the nose. And this is a scan you pick up. Now, if the dye is leaking at the same time while shooting, the same thing you can pick up on MRI as well. Like you saw the 3D drive, it can pick up the image very well if there is a leak at that same time. So why the need of CT scan or CT cystonogram? CT cystonogram has the biggest disadvantage of injecting an intrathecal iodinated contrast, which has its own complication. We have seen patients long back developing transverse myelitis after injecting intrathecal iodinated contrast. The disadvantage is the contrast can give reaction, can lead to complete paralysis, neurological complication, a lot of neurological complications. This contrast stays in the intrathecal space for 2 to 3 hours. During you need to scan again and again, CT scan and again to see if any contrast coming down in the nose. And since CT has a radiation, shooting CT scan and again during that period can be hazardous to patients. One CT scan is equal to, the radiation hazard of one CT scan is equal to 400 X-rays. Imagine in 2 to 3 hours time until you get the CSF leak, until the CT cystonogram contrast is there in the intrathecal space, you shoot CT scan 5 to 10 times, how much hazard you are giving. And still, if that period of time, if there is no active CSF leak, it may turn out to be negative. In spite of having a CSF leak, the CT cystonogram can turn out to be negative. So what is the investigation of choice in intermittent situation? This is our investigation of choice, and from literature the best in the world. Intrathecal gadolinium. It is 1,000 times safer than the intrathecal iodinated contrast used for CT cystonogram, number one. Number two, it stays in intrathecal space for almost 24 hours. And number three, it is longer period. So in intermittent CSF rhinorrhea, you get longer time for the contrast to stay in the intrathecal space and longer time for you to shoot MRI scan again and again to pick up that. So the yield, the overall opportunity to catch the CSF leak is much more. And number three, since MRI is free of radiation, you can shoot again and again MRI until you get the leak, intermittent leak, for next 24 hours. So the chances of getting a negative, in spite of a leak, a negative MRI are very, very less. So this is the investigation of choice to pick up the intermittent CSF leak, gadolinium enhanced MR cysternography. This is the investigation of choice. In intermittent leak, when the leak is continuous, your simple 3D dye MRI will pick up. Now in situations, sometimes, let me give you certain examples. This example, the another imaging, see the onus is on the surgeon many a times. You order MR cysternography or MRI brain for the CSF, the radiologist will do 1 or 2 sequence and you don't get any positive yield out of that. The onus is on the surgeon to order right sequences. The time is now to order MRI yourself, that what sequences are required in particular pathology you are looking at. So on screen what you see, this is 3D dye. You saw just now, 3D dye means the brain is suppressed and the CSF is bright. See, the fluid is bright everywhere. And on the other side is opposite sequence. This is 3D flare, where the brain is bright and the CSF is dark. Inverse imaging, and that helps in differential diagnosis of a CSF rhinorrhea and sinusitis. If there is sinusitis, this is bright on the drive as well as bright on the 3D flare as well. But you saw in 3D flare, it is inverse imaging, the CSF is dark. So if there is a CSF, it will not appear bright on 3D flare. Had this been sinusitis, it would appear bright on 3D flare. On 3D drive, the sinusitis, the fluid, the CSF, everything will appear bright. The 3D drive cannot differentiate between any fluid, whether it is CSF or sinusitis. But 3D flare can easily differentiate. The sinusitis will appear bright, but the CSF will appear dark, and that is the investigation of choice when needed in cases of doubtful CSF rhinorias, in cases of difficult areas. You must have these two sequences to know whether it is CSF rhinoria or sinusitis. Many a time this differential diagnosis patient come with unilateral discharge, hardly any sinusitis, and you suspect a CSF rhinoria. Now see this imaging. This is T2 weighted, again the CSF in continuity of the temporal lobe of the brain, and see this fluid is coming in the nose, the signal. Now whether it is sinusitis or CSF, again how can you differentiate? See this on flare. On flare, see this dark shade of CSF coming in the nose. This is definitely CSF, not sinusitis. Had this been sinusitis, it would have been bright. See on the sinusitis on the opposite side, it's bright on both sequences, but the CSF here is dark. This is the investigation of choice. These two sequences, if you order, you can diagnose or you can rule out any CSF rhinoria. You can differentiate very well from sinusitis, whether it is sinusitis or CSF rhinoria, because the T2 weighted MRI cannot differentiate. All fluid is same for T2 weighted, whether CSF or sinusitis. So this is important sequence to differentiate whether CSF or sinusitis. And in intermittent cases, the intrathecal gadolinium enhanced MR cysternography. So these are the three investigations we must keep in mind when we are suspecting a case of CSF rhinoria. Any other thing you want me to show quickly, or any questions, sir? Hello?
Now we can proceed to case.
Yeah. I think the case being induced, getting ready in 2-3 minutes. So we can take questions or anything you want me to show meantime. I can.
Sir, good morning.
Good morning.
Sir, one question from my side, Dr. Samir here.
Yes.
Many times we see that after doing this cysternography,
Yeah.
because of chemical irritation, the leak stops. So in such cases, would you still go ahead with the surgery, and how do you convince the patient?
See, yes, your question is valid. Number one, if there is a dural defect for which you are looking at, it cannot stop. Because of edema, you may not find leak that profuse in the coming period, but it is never going to stop if it is a leak. So it is because of dural edema, one may find the dural leak indiscernible, or the leak reduced, or no leak for some time, and one may be in the feeling that there is no leak, or the cysternography itself has blocked the leak. Leak is going to come back, the edema is going to reduce, and it is going to come back. So never rely on that situation that the leak has stopped. If there is a leak, you have to stop it.
Good morning, sir. Dr. Jaskaran here, sir.
Yes.
Yes.
Man.
How are you, sir?
Good. Good to hear from you.
Sir, can you just elaborate the workup protocol for CSF cases in a benign intracranial hypertension, sir? How do we work up for a benign intracranial hypertension?
Always in benign intracranial hypertension, always order the sequences I mentioned. Multiplanar, this 3D drive, 3D flare, and MR venogram. You know what happens? What is benign intracranial hypertension? I mentioned in the beginning, the amount of CSF produced every day is getting absorbed in the arachnoid villi. Now, if there is high venous pressure in the brain, this CSF is absorbed along a pressure gradient from the CSF space in the arachnoid to the arachnoid villi in the venous sinuses. Now, if venous pressure is more, the gradient is not formed and the CSF is not adequately absorbed, leading to a situation of benign intracranial hypertension. The CSF pressure is more because of inadequate absorption. So in those situations, you need to assess all the reasons for the inadequate absorption in the arachnoid villi. So besides this 3D flare and the 3D dive sequence, number one, you should see the condition of benign intracranial hypertension by MRI scan. Look at this sagittal MRI. Can you see this? This bright arachnoid is almost coming and replacing the sella completely. Can you see this? The pituitary gland is compressed to this minimum, and rest of the sella is replaced by fluid pouch. Can you see this? This is one of the important sign of benign intracranial hypertension. You can see when the fluid is replaced by, the sella is replaced by fluid. Could you see? Number one.
sir.
Number two, can you see the optic nerve buckling? See this. This optic nerve right from the disc here, it goes intracranially forming the optic tract, optic chiasmoid tract. Now this optic nerve is loosely placed in the orbit, in the orbital flat, right from the disc to the orbital apex. Now this CSF sheath, all the three meninges are carried along the optic nerve right to the disc containing the CSF space. Now what happens if the CSF pressure is more? The sheath gets engorged and this optic nerve starts buckling. Rather than a straightforward nerve, it starts buckling. That is another sign of high intracranial pressure. And number three, the venogram. We have seen cases of venous stenosis. We have seen, let me show you some pictures. We have seen cases of venous stenosis many a times, where is high venous pressure, where this fluid is not absorbed. Let me show you. See this. See this picture. See, this is the transverse sinus. The arachnoid villi are in the transverse sinus. Now see, the opposite transverse sinus is absent. It is completely thrombosed. So the pressure gradient is high. And if this region is overlooked, if you are not knowing this fact without this MR venogram, see this venous stenosis in the other picture. If you are not aware of this, the CSF is not getting absorbed adequately and pressure will remain persistent high. If you ignore this and seal the CSF leak, it is bound to come back somewhere else. So in radiological imaging of a benign intracranial hypertension, spontaneous CSF rhinorias, which are basically a reflection of benign intracranial hypertension. Manifestation of benign intracranial hypertension is CSF rhinoria. If there is persistent elevated pressure above, it is going to give way. And if this kind of a finding is ignored, your whatever seal you do is not going to stay, or if it is sealed, it is going to come back at other place. So we must have a thorough radiological investigation in benign intracranial hypertension to know if any obvious cause of BI, benign intracranial hypertension being there. We need to treat the underlying cause. Otherwise, whatever CSF leak you seal is not going to work for long. Jaskaran, anything else?
Sir, one more question, sir.
Yes, please.
What is the indication for lumbar puncture in these cases, sir?
Lumbar puncture is reserved for certain challenging situations, not always. Lumbar puncture is a good way of reducing the intracranial pressure temporarily by draining the CSF intermittently, preventing pressure from building up. And this helps in the post-operative period to keep your seal in place. It doesn't displace the seal. The seal can be effectively get matured in 5-7 days, and then you remove the drain. So the pressure can be sustained, better by the new seal. Now, routinely it is not required. Rather, you should seal in a normal pressure situation when the pressure is high, so you can ensure your seal well. Now, what are the challenging situations when this kind of a drainage is required to keep your seal perfect? In challenging situation, number one, if my patient is post-radiation, some surgery was done post-radiation and a CSF leak in the vicinity of the radiotherapy, the healing is not very effective as compared to the normal situation. Healing may be delayed and you need some support for the seal not to get displaced. The lumbar drain is one of them. In patients with very high intracranial pressure, to keep the seal in place for some time until the seal gets matured. In situation when you have a large defect and you don't have a vascularized flap, Normally, vascularized flaps are the best way to seal the defects and give you ready-made tissue over there, vascularity over there. In large defects and you are lacking a vascularized flap because of the previous nasal surgery, you don't have hard heart, you don't have lateral nasal wall flap, and you are still sealing with the free tissues only. It is always better to do a lumbar drain to make chances of that seal more effective. In revision cases, you have done once, you have done twice, and you are operating again, don't take a chance. Don't make the patient lose faith in you. In the next time, put a lumbar drain to increase your chances of seal not getting displaced. So these are indications where you can utilize a lumbar drain as an adjuvant method to improve your sealing, not solely lumbar drain as an answer. I hope it answers. Hello?
Yes.
Yes, sir.
So our case is ready. So let's get on to the first case. We are already running behind the schedule. So this case, what we are doing is the CSF leak from the cribriform plate. This patient looks like having high pressure as well. This patient, is a spontaneous CSF rhinorrhea. Mostly such rhinorias happen in middle-aged obese patients. Middle-aged obese patient with high intra-abdominal pressure leading to high venous pressure in the brain. The pressure gradient is affected for the absorption of the CSF, and ultimately they develop benign intracranial hypertension and spontaneous rhinorrhea. This is a significant chunk of patients they present like this. So in such patients, post-operatively a watch on the pressure is very, very important. In this patient, our aim of sealing in the surgical part, I will show you how to identify the defect, how to make the surrounding receptive for your seal to make it completely raw, how to make the surface all around flat to take your seal effectively, and how to prevent infection when you use free tissue at the skull base by bringing in ready-made vascularity. At the same time, dealing at the skull base in the vicinity of all sinuses, in the vicinity of frontal sinus, sphenoid sinus there, we should make sure at the end of the surgery that our sinuses are not blocked, their ventilation drainage is not blocked, to give secondary sinusitis in that region. You have sealed the CSF and ultimately blocked the sinus and given secondary sinusitis. Now imagine the dealing with that sinusitis in the vicinity of the skull base repair, how difficult it is going to be. So we have to be very, very cautious, in dealing with the CSF rhinorrhea, looking at the future issues. This patient, I could not show you. Can you change to this? इसको बदल दोगे भाई साहब? Sir, इसको इसमें लगा दोगे? This patient, let me show you the pressure situation. Is the MRI changed? Hello?
Yes. Yes, yes.
Can you see the sella? The arachnoid pouch fluid is coming into the sella because of the high pressure, and the entire sella is replaced. Can you see?
Yes, yes.
There is no cellular tissue visible in the sella because this arachnoid, because of the high pressure, this fluid pouch is coming from diaphragm and replacing the entire sella. So this is a classical example of a high pressure CSF leak. And this you can imagine that we are going to most likely going to find a meningocele in this patient. High pressure leak patient presents with herniation of the meninges presenting as a meningocele or meningoencephalocele. And this patient, I suspect a small meningocele at the skull base, which we are going to expose now. So like in any other skull base surgery, a goal of surgery, we have already discussed. The plan of surgery will be exposure, exposure and exposure. My 90% of the time will be invested in exposure. Last 10% will be utilized in sealing the defect, and that will be a cakewalk once it is completely exposed, and we'll seal with a neighborhood or any neighboring tissue using as a vascularized flap to give a ready-made vascularity to that region, ready-made mucosalization so that it can prevent infection at the skull base later on in the post-operative period. So let's go ahead.
For this session, we invite Dr. Ravindra Bansal from Gwalior and Dr. Ashutosh Nima from Satna to chair this session.
Bhai.
Recording in progress.
आ जाओ. कौन सा है?
इसमें ला रहा हूँ.
है?
नीचे से ध्यान नीचे.
लगा के देखना. लगा के देखिए. लाइट ऑन करना. पिक्चर दिखा. राइट साइड. कैमरा से सेटिंग चेंज कर. वो कर. वो. और वापस दबा. वापस दबा कैमरा को. ऊपर ले. हाँ ये इसमें आ. साइड का दबा. स्टैंडर्ड पे ले. अब दिखा. हेलो. कुछ हुआ क्या? उसका जुगाड़ आगे का. और एक और था ना.
रोमस है तो थायराइड का इमेजिंग नहीं है, बाकियों का फिल्म है.
ठीक है. Hello, auditorium. Go. Hello, auditorium.
Yes.
Yes, sir. Am I audible?
Yes, very well.
So, are you getting any endoscopic picture there?
Yes, we are getting.
So, this is right-sided CSF rhinorrhea. Our target area of interest is in the roof of the ethmoids. We have to dissect through the ethmoids. We have to make the entire roof, we have to prepare that to take our seal. And in order to dissect the entire roof, you need to go through the sinuses. And all dependent sinuses drain through the ethmoids only. So at the same time, we have to make sure that the end of the seal, all sinuses should remain open. See, this kind of a surgery you need to understand once. If it is done properly, there is no question of a situation of failure or anything. Such question arises when you consider this is like sealing a puncture. This is not like sealing a puncture. You have to thoroughly expose the skull base and reconstruct the skull base. It is not sealing the puncture. It is all about reconstructing the entire skull base. And in order to reconstruct around the site of the leak, you have to have at least a centimeter area around, completely bare, exposed and flat. And that is the key to success. At the end of the surgery, we will seal it or we will line with a vascularized flap to give it a ready-made mucosalization. Now, this is on the right side. I hope you are getting the endoscopic picture. So I am just decongesting the right nose with my marrow cell pieces. This is simple marrow cell soaked in saline adrenaline to decongest. See, this is single application and you see how the nose opens up. In single application, nose opens up. This is high deviation, you can see. Behind is the middle turbinate, you can see. And our area of interest is here in the roof, medial to the middle turbinate. It is going to be behind, close to the, in the vicinity of the anterethmoidal artery where the cribriform plate is. Most of the leaks are in the vicinity of the anterethmoidal artery region. So let's go and expose the area of interest. Can you see something?
Yes, sir.
What is this?
The meningocele.
That's the meningocele. See, this is our area of interest. I told you these high pressure leaks mostly present as meningocele patla. After single decongestion in a nose which was looking completely blocked, you can see your area of interest, the target area. This meningocele is exposed to the nasal environment, exposed to the microbes in this region and can get infected. See how it is leaking. Can you see?
Yes, sir.
The constant CSF leak. Now, one can think of sealing it like sealing a puncture. But believe me, it is never going to work. You have to understand the science and reconstruct the skull base to give a permanent seal. No question of leaking in the future. Something like that you need to ensure, and for that we need to do a lot of things. We need to dissect through the paranasal sinuses. We need to expose this skull base completely. See this? That's the seal. That's the leak. I hope it is clearly visible.
Yes, sir. Very well.
So this was expected from the MRI. The CSF space extending down below, lined by the meninges and presenting as meningocele. So now the biggest obstacle
What
in
is the
this,
concentration of adrenaline that you are using?
this is being young patient, we are using 1:2. Depending upon the patient's profile, elderly, cardiac patients, we can keep reducing the concentration.
Okay.
But in younger, we can even use pure adrenaline because we are using only topical, we don't inject at all in the nose. If any adrenaline happens to transgress in the systemic circulation, in a labile patient, cardiovascular labile patient can create hazards. And that is not expected in such benign surgeries. So, I'm just preparing, decongesting. Heart rate. Okay. So, sir. Yes, sir. Because of that, yes. So I'm using these marrow cell pieces. They open up the space. I am not packing them hard. I am just applying my adrenaline to the mucosal surface to decongest the capillaries. The single decongestion itself prevents further systemic absorption of the capillaries and it is ultra safe. See the obstacle. Obstacle is see this area you need to flatten completely. You have to make it flat to accept your seal. So my first is to cut the middle turbinate, bring it down. We have two sinus cases. One is primary revision later on. So we'll discuss the sinus surgery later on. This right now, see the vessel at the middle turbinate end. This is an important vessel. Sometimes it becomes the basis of a middle turbinate flap. See this? At the base of the middle turbinate is all branches of sphenopalatine. Pandal, no? Yeah. So my first is to get this middle turbinates away from the field, because we have to reach out to the skull base efficiently. Second thing, at the same time, we have to ensure that our all other sinuses they do not get blocked. So we have to do a sort of sinus dissection all the way. I mentioned my 90% of the time would be invested in exposure, exposure, and exposure. So quickly, though it is not the sinus surgery I am doing, this is your uncinate, this is your bulla ethmodalis, this is your maxillary sinus. Though we don't intend to do any sinus surgery, but still what I am doing here, at the end of the surgery I'll show you how my sinuses which are dependent for their aeration down the ethmoid channels do not get blocked and give secondary sinusitis. So this is a part of exposure. I am doing that quickly. That's the maxillary sinus on this side, the uncinate process on this side. बंद हो गया, बंद है यार, बंद. That's the bulla ethmodalis, the biggest cell in this region. My area of interest is here, right up at the skull base. We'll make sure on the table that our seal should be adequate to reconstruct the skull base. Uncinate the remaining turbinate. Upper part of the uncinate. I am taking quickly. We'll discuss such steps in details from sinus surgery perspective later. See now, once I see the upper part of the uncinate, immediately the next structure come in view is this lamina papyracea. See the lamina papyracea? There.
Yes, sir.
That is the lateral limit of your entire corridor. And we can easily reach quickly in no time to the lateral limit. Once you see the upper part of the uncinate, see your lateral limit, that is lamina papyracea, and make sure you don't cross that. That's the bulla I have already taken. So this dissection I will go fast because this is not the sinus surgery, but yes, we need this. I will show you later the need of doing this.
Sir, is it 0 degree scope or 70 degree
Yeah,
scope?
still 0 degree only. So quickly I am just exposing and exposing all ethmoids. Behind this is your superior turbinate. Can you see behind the ostium of the sphenoid sinus? Behind is the ostium of the sphenoid sinus there.
Yes, yes, sir.
So this I am going fast. Pani nahi dalta. Pani dalta rehna. See, all this bone I can remove. Quickly. Next 10 minutes we'll be through this entire dissection part and focus on the area of interest. This is ethmoids, antithmoids getting into postethmoid. This is your superior turbinate. This is your sphenoid sinus. Sphenoid, widening of the sphenoid by this. Under vision. Now the same turbinate, the postethmoids following from posterior to anterior. Simple 0 degree so far, and the postethmoidal skull base getting exposed. This is the remnant of the turbinate. Keep following this. Now give me scissors. How? Oh, all because of Dubey, sir. Now see more turbinate I have scored, and see my area of interest is further getting exposed. Yeah. बंद हो गया. Now give me 70 degree for a while. The suction कम जो थोड़ा डबल कर देना suction. कर. Now just taking the 70 degree to look up. कमजोर है. वो स्टोर वाला है क्या? स्टोर है. So I am changing to 70 degree here. See 70 degree, and this is the upper part of the turbinate to This is your skull base. See all the way from behind the skull base, skull base, skull base. This is the region of the meningocele. Further reducing my turbinate, flattening the turbinate completely, and just above that is going to be the frontal drainage pathway. Reaching there to ensure that my frontal sinus after the seal doesn't get blocked. That is the frontal sinus above. You can see all sinuses dissected.
Yes, sir.
So this was done quickly. That is not our domain. Our domain was here. Why did we all this? To expose our region efficiently. दूसरा 70 है क्या? Now see, this is the side of the effect. हाँ है, दूसरा दो है 70 है. कौन सा? अपने पास से दे दे. Now. That's the 70 degree picture. Wash करना. Look. क्या था ये तो एक मिनट see just to orient you रुकना. That is the frontal sinus, that is suprabular cell, this is your anterethmoidal artery, can you see?
Yes.
And see this artery turning toward the cribriform plate, and that is where the leak is. Can you see very clear? This leak is always in the vicinity of the anterethmoidal artery. Such meningoceles because of high intracranial pressure. This is the most likely site. And what we have achieved all around, we have seen. Now the next step is to flatten the region completely. Reverse the now. This entire region I will make flat and raw to accept my seal, which can stick to raw area well. So some more that is frontal sinus. All this turbinate, all this you have to flatten. This is reverse blade. The so-called, we call it a skull base blade. This is the mucosa over the anterethmoidal artery. Yes. Now, to demucosalize, either you remove the mucosa and make it bare, and in areas where you cannot remove the mucosa thoroughly, you can use the coagulator to devitalize that. You have both the options. So my exposure is getting better now. Let me make it much clearer. Next 10 minutes we'll be through with the entire exposure and preparation part to seal the defect. See, after dissecting through the ethmoids, my target area is very, very clear and directly in front of us. See, because of the high pressure, entire cribriform plate is affected. See this? One can overlook this region behind. You have to reconstruct the entire skull base. See this entire skull base. If you see the close up, even this skull base is not healthy. See this? So it is not about the puncture sealing. The 140 there. It is about complete reconstruction of the skull base on that side. So let me further 40. I hope the picture is good there.
Yes, sir.
Dr. Bansal, feel free to interrupt me at any point of time. If you are, if you have any query or suggestion, banda.
Sure. This is 70-degree scope now, right?
Yeah, this is 70-degree now. See, there is a lot of mucosa in the region. So I will further prepare this demucosalize. Demucosalize. So that my seal can stay effectively on the raw area. See, this side, the ethmoidal roof, I have already made bare. Very clear? Now, cobbleter. Now, this mucosa from this region cannot be elevated completely more. So, what we'll do? We will devitalize this mucosa and make it completely flat. गीला रखना कौन सा? Now, see what I am doing? I am devitalizing this mucosa. Whatever mucosa I cannot remove from the, हटाओ ना यार, पूरा करो ना उसको, करो ना, किया? नहीं किया. This mucosa I am devitalizing thoroughly, and whatever my meningocele will also be coagulated. Now this surrounding, almost a centimeter, I am going to devitalize for my seal all around to come in place. These are very small defects which present as meningocele. This side I have already, medial to that, I have already removed the mucosa and made the skull base bare. On this side, now give me, see the area. These defects have high pressure. These defects do not have substantial bony defects. Very small bony defect and a big herniation. What herniation? The arachnoid. Arachnoid herniation. And which arachnoids, the beauty of the cobbleter is it seals the arachnoid layers. Now see, whatever the thin bone, section से दिखा, हटा, section से हटा, bone हटा, ये bone हटा. Yeah, I am removing this thin bone all the way. Further sealing, see this, the cobbleter itself seals the arachnoids. It seals the arachnoids like this. Seals the arachnoid effectively, the cobbleter itself. Now, give me the Merocell. Let me show you the site of leak now, if there is any. Most of the time, the cobbleter itself seals the arachnoid layers and close the CSF leak. Let me show you. Now, that is your frontal sinus. Yes, sir. कहाँ की? अच्छा अच्छा, तो मैं वेट करता हूँ. हाँ, कोई दिक्कत नहीं, आप बता देना. हाँ हाँ हाँ.
पहले बाइपोलर से करते थे तो सर
फील्ड कार्पेट कट ले ले वो बना दिया ग्लो आ गया क्या सर? तो वो इसको दे दो, ये बना देगा नीचे से। हो गया काम मेरा तो। हाँ कोई दिक्कत नहीं।
सर बाइपोलर से भी हम लोग जो लीकिंग सेट है हम लोग फील कर सकते
ये इससे तगड़ा नहीं हो सकता। कितना इजी है ना, है ना एकदम बंद,
हैं।
मस्त बंद हो गया ना एकदम। ना ना जब तक बना ही देता है ना। हो गया काम। CSF तो बंद हो गया। फैट, ओनली फैट, नो फेशिया। कोई अपना पास है क्या एंटीबायोटिक, कोई जेंटामाइसिन कुछ? हाँ रिफाम्पिसिन तो होगा नहीं यहाँ, नीचे है क्या? कैप्सूल कैप्सूल तो 600 mg के 2 कैप्सूल मंगा लो। 600 वो बताएंगे ना लाइट आते ही। ला रहे क्या? बहुत है यार। क्या करेगा तो अभी तो ये वो ग्लू का है टेटो अपना बताना लाइट आती। ये बोलो हेलो 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 सर सर कोई फेशिया दबाने का सिस्टम है क्या? वो लगाते हो जो फेशिया कान में, कोई सिल्ली जैसी प्रेस करते हो फेशिया दोनों तरफ से दबा के, समझ गए ना? हाँ कुछ है क्या? नहीं हो तो बता दो। हाँ वो दे दो। हाँ बस वो दे दो, उससे दबा लेंगे। हेलो नहीं आई लाइट। हेलो पेटो हो गया? कोई लाइटर लगा के उसके पास में ले लो सर। है माचिस? हाँ सर क्या क्या मांग रहे हैं? केस कर रहे हो, मजाक कर रहे हो?
Hello.
Hello. Hello.
Hello.
Hello, sir.
Yes. Now we are getting the audio also.
Okay, you are getting the audio and video both?
Yes, sir.
ये लाइट जलाओ ना इसकी। इसकी लाइट किसने बंद करी है? Yeah. So we didn't do anything. I think you were watching till I was coagulating the skull base.
Endoscopic
Correct?
picture, please.
We are getting outside picture. Yes, sir. Now we get getting endoscopic picture.
Are you getting the endoscopic picture?
Yes, sir.
So I stopped. What I did at the end was, you saw me coagulating the mucosa.
Yes, sir.
You remember? See this. Let me show what I have done. We have, see this bare, made this ethmoidal roof bare.
Yes, sir.
This is our region of the cribriform plate. Can you see this? This thin
Yes,
plate. And there was a defect here with the meningocele. Could you see? That is completely coagulated and the leak is completely stopped. The reason being, once you use the coagulator, all the layers of meninges get fused. They get coagulated and get fused and the leak automatically stops. Can you see very clear? There is no leak.
Yes, sir.
See, I made this 1 centimeter area on this side and this side 1 centimeter completely bare. With no mucosa, no active mucosa in the place to secrete any mucin. Could you see very clear?
Yes, sir.
Thirdly, my entire roof is very flat and in front of me. There is no hidden area. I can see my frontal sinus above, my sphenoid sinus down, the sphenoid sinus here and the maxillary sinus here. And all ethmoidal roof is bare. My aim, I told you, is not to seal the puncture. To reconstruct the ipsilateral skull base for prevention of future leak. Just do it and forget about it. So, in such high pressure leaks particularly, I mentioned that we are going to have a very small skull base defects in such cases and large meningocele coming down. So once you coagulate the meningocele, the meninges fuse and the leak itself stops. And in this situation, see here, in this situation here, we can see without doing anything much, our coagulator has sealed it completely. Something is spoiling the telescope. And see the area of the skull base. I hope the picture is very clear.
Yes, sir.
And there is no leak at all. Just with the coagulator. Now we have to reconstruct the skull base. See this. This is your ethmoidal roof. That is your cribriform. All this ethmoidal roof, we made it bare by removal of the mucosa. Now this is your cribriform. See this thin cribriform plate, thin cribriform. And this was the region of the meningocele coming out. And this is nasal septum. So this thin plate of cribriform bone, which was leaking, we have completely sealed with the coagulator. And this area is completely exposed as well. So now we'll make this skull base thick. We will make sure this heals as a mature scar, thick and mature scar. See if I give you the close-up of the skull base. See this close-up of the skull base.
Yes, sir. Sir, advantage of coagulator over bipolar cautery?
Yeah, coagulator is amazing. So now the best part is the irrigation. Continuous irrigation doesn't allow the temperature to go high at the skull base and give a collateral damage. Constant irrigation and constant suction is the beauty. See this?
Yes, sir.
The skull base is completely sealed up, completely exposed in cases with a large bony defect. We nowadays in skull base surgery create bony defects in centimeters and then seal them. Here this is high pressure leak. You could see the pressure in that and now completely silent. See how Coblator is done the remarkable job. Now, but this is not enough. The inside pressure can ruin everything again. So what we are going to do now is we are going to use the multiple layers to line it to make a thick scar. I am changing to 0 degree again. 0 degree. So suction. What I will ensure is a thick scar. यही था क्या पहले 0 degree. See the nasal cavity. All sinuses you can see. Now. And you can see your area of interest above. See that? Now,
Yes, sir.
what I will ensure that I will raise a vascularized flap to line this area. The reason being, I will use some fat to further substantiate the skull base to make it thick, and then cover this entire skull base with a vascularized flap for the primary healing. Primary healing, entire area will heal primarily with a thick flap to make sure that the entire region is completely covered to prevent future CSF leak. This may make, while elevating the flap, the septal area raw, which is not of much significance. A secondary infection at the skull base is much more dangerous than at the septum raw area. So what I will do, I will not raise a classical Haddad. See this, I need this flap for this region only. So I will just raise a modified Haddad, not a big one. So what important is for the Haddad? This is your sphenoid ostium.
Yes.
The vessel for the Haddad runs on the anterior surface of the sphenoid, few millimeters below the ostium. So what I will do, this is the level of the nasopharynx. I'll make one incision below, and then come down towards the floor and come anteriorly. I am not raising a classical Haddad. On one incision above this, see this such a broad pedicle, and come anteriorly. And little higher to take this. See, I am not raising a classical Haddad. I am not going right till the level of the floor. I am not going right till the level of the vestibule. And this is a reasonably good wide flap for me. See this? A modified according to the need. In minutes time, this is a very, very vascular flap. A very reliable like PMMC for the head and neck. Has a reliable pedicle vessel. See, there is no infiltration. And still you can elevate in the plane. We being otolaryngologists used to do septal surgery, used to elevate these flaps. One can still elevate. See, this is without infiltration. So it doesn't take more than 2 minutes to complete this exercise, and then it will be such a reliable flap to cover the entire skull base. Aim is to reconstruct the skull base. Aim is to prevent the leak from the ipsilateral plate. It is not the one place, it is the entire plate which is affected in high pressure leaks. Micro leaks are there and one can easily miss and, see this. See this. One can easily, I am elevating flap with my scissors only. Once you are in plane, you can elevate easily. like this.
So do you use radar flap for the high pressure leak only or for each
No,
and
no,
every
all
cases?
skull base leaks, primary spontaneous rhinorias. See, the aim is not about the sealing. Aim is about giving a ready-made tissue there. Ready-made vascularized tissue there. Yes. We are giving a ready-made vascularity over there. And accordingly, you can lengthen the flap as and when required. The width and the length depends upon the leak, the size and location. See this?
Yes, sir.
This you can easily take over there. That's an amazing flap. See, my area of interest, the level of the skull base which can give meningitis, potential meningitis, will be covered with this flap so easily now. This will leave my septum raw, which can heal in couple of weeks without giving much issues. But yes, if I don't seal the skull base with this primary, healing, if I leave the free tissue over there, free tissue can get infected and can invite a meningitis. So that's the beauty of this flap, to cover everything. This is just a rehearsal now. Now, give me 70 degree. Cobbleter देना है. See, the margin of the flap can keep on bleeding. You can cobblate them from the area where you have elevated. The septal margins, because they can keep on bleeding otherwise. So I can easily cobblate the margins to prevent post-operative oozing. Now the 70 degree and final sealing. Already the CSF is stopped. So we'll now carpet the skull base. Carpet the skull base to give it a strength. Let me show you, and next 5 minutes we'll be through. And at the end of the surgery, we'll discuss what we have achieved. This is our area of interest. The entire cribriform being covered with a vascularized flap. See the area? I hope the picture is good.
Yes, sir.
No leak. Let's see once more. The close up. Let's do the close up once again. See, you saw a high pressure leak half an hour before. Pulsating and leaking. Could you see that? Remember?
Yes, sir.
And now completely sealed. Now number one, I need बिल्कुल पतला देना, बिल्कुल पतला और पतला कर, ये हटा दे सब. I need a very thin carpet of fat. Fat is one of the best material to stick to take up, can resist without vascularity for some time and give a thick mature scar. That is the best material. Out of all, the fat is the best material. So what I am doing, just a minute, we will make a layer of fat like a fascia. दिखा वो जैसे जस्ट
Sir, from
नहीं,
which
वो
part you have
knife.
harvested the fat?
अरे छोड़ो मैं उससे दिखा दूंगा, नाइफ दो, एंडोस्कोप से दिखा दूंगा। पेटवा दिखा, पेटवा एंडोस्कोप ला 70 है। No, leave it. Can you see this fat tissue
No, sir. we are
with
not able to see.
compressed
Yes,
and
sir, now.
spread? This is pure fat
Yes.
only, no fascia at all.
Yes, sir.
And this I will use as a layer to strengthen my skull base, basically.
Sir, fat from the thigh.
Thigh fat is more knitted than the abdominal fat. We always prefer the fat from the thigh. So this is just fat, nothing else. And now we will take it inside. This fat is just to line the skull base, to give a thick mature scar. That's all. Let me show you. See the region of the cribriform. This is the first material to come in contact with the skull base. See, this is the fat which we have compressed in a fashion to fill this area and cover this like a carpet. This is the thin cribriform region. This is intentionally filling this like a carpet to give a thick scar at the region of the cribriform plate. This is what we want to prevent any future leak. Can you see how the fat is spread?
Yes, sir.
This is to invite a thick scar. My skull base should not leak again from this cribriform, this side cribriform. This is what I want to ensure. Now, give me the glue. See this? Now I will use glue to keep it in place as well as invite the fibroblastic reaction. Glue has an advantage of not only acting as a glue to adhere the tissues, but more importantly to invite the fibroblast to that region to give a thick scar. Fibroblastic reaction is important to induce a thick scar, and that is the function of the glue additionally. So now in a minute's time we'll our flap is already there in place and kept aside. And now the glue is ready. I have already selectively placed my fat layer. Fat is being used as a layer like fascia, selectively to cover the cribriform only. The defect was there in the entire cribriform. The entire cribriform was thin. It is not like a puncture sealing. It can come from the other side, from the nearby side. If you don't make the entire skull base, perfect. Now see, this is my tissue glue. This is just to keep this flap at margins all around and inducing the fibroblastic reaction. The entire skull base is reconstructed. And now this entire area beyond that, beyond the cribriform, all around, see at the end what I am ensuring that my frontal sinus remains open. Had I not opened the frontal sinus, assuming frontal being there, a narrow opening with a reconstruction in the vicinity could easily lead to blockage of the frontal drainage and frontal sinusitis, and we have got lot many cases of such CSF leak repaired and ultimately secondary frontal sinusitis, and that is a disaster. Now this entire region beyond the fat, see this? Imagine how thick the skull base would be in this side after this. Now see, my sphenoid is open. My sphenoid remains wide open. My frontal remains wide open. My maxillary is this side. And this vascularized flap has completely covered the cribriform plate from all around for future. In this side in the future, I don't see any possibility of future CSF leak. The multiple small defects in the cribriform which one can easily overlook is the reason for a revision surgery, a persistent problem. Assuming that once defect is sealed, with the continuous pressure going on, the neighboring micro defect will open up in future and give a persistent problem. See now, this glue which makes like a rubber now, it becomes rubbery. See everything in place. Now how much layers we have placed? The first layer was fat soaked in rifampicin, an antibiotic to prevent airborne staph infection, and the major region of autolysis of the fat is the infection, and major infection almost always it is the staph aureus. So that is something can be prevented, and now the entire region is covered by vascularized flap. In view, your frontal and the sphenoid sinuses remain wide open. That is the beauty. And this would not be possible to know at the end of surgery without this sinus dissection. So looking at the future issues, why I covered with the vascularized flap? Because now my skull base is covered with a vascularized flap. Ready-made mucosa, ready-made vascularity, so chances of secondary infection are over. There is no area, no raw area to invite infection. It is all vascularized. Your antibiotic will reach directly to the skull base. So it is not about the puncture sealing. The time has changed. You have to reconstruct the skull base to ensure that this side skull base will never leak. Now this is your gel foam. Now this is all reinforcement now. Actual job is done. Reinforcements means soak with a antibiotic again, gentamicin or ciprofloxacin, whatever. See this marrow cell I have soaked will give a constant pressure. Marrow cell is the ability to swell up much more than its volume, much more than its weight. And it swells up, makes a jelly that sticks well, and that gives a constant pressure. That gives a constant pressure. Now this jelly will give a constant pressure. See this pressure. This is amazing material to give constant pressure. See my all sinuses, and now this pressure I will keep here for a couple of days. So what I will do now, whatever I have applied so far is going to stay in place for life. The fat, the fascia, the flap, and the gel form, which is need not to be removed, absorbable. Now I will keep it pressed for a while. What I am doing, I am interposing with a non-sticky layer, maybe silastic sheet or any non-sticky layer. See this? And now I will press with the marrow cell. So once I remove the marrow cell, it will not stick to the gel form and the entire assembly, and it will not disturb it. Otherwise, while removing the gel form, it can pull up the entire assembly and you are back to square. So that's a multi-layer repair. See this, what I am doing. Now this is my marrow cell piece. I want to exert the maximum pressure where required. See this? This is your area of interest. This is your area of interest. So my marrow cell will give constant pressure. How it will give? I will bring another marrow cell perpendicular to it right up to the anterior nares to keep it pressed. So my entire assembly will start from the anterior nares to the skull base, fixed for a couple of days. 0 degree. See now, this will keep pressed like this, the entire skull base. So what I will do, I will keep it pressed with a vertical marrow cell. See this? This marrow cell is being pressed with another marrow cell. That's it. And I will make them swell with the povidone iodine. Full of flowers. So the entire assembly, remains fixed till the anterior nair. So it will not get displaced. See this? Till here, till the anterior nares, everything is pressed. So this will remain pressed like this, right from the anterior nares, one marrow cell pressing on another marrow cell, on the silastic pressing on the gel form uniformly, and gel form is pressing on the flap, which is uniformly covering and pressing on the fat, which is covering the skull base. So this is a complete assembly. Even the bombardment will not displace it. The beauty is, the aim was not to seal the puncture. Aim was to reconstruct the skull base. You cannot reconstruct the entire ipsilateral cribiform, which is deformed, punctured, maybe at multiple places due to ongoing high pressure. Sealing a single puncture will not help it, and it is bound to come back again. It gives a feel good that you stop the seal with a minimal effort. Why to do all this? Looking at a long run, nothing is going to work like this. So the entire area was dissected, almost 1 centimeter surrounding made flat, completely flat, demucosalized, CSF sealed. Here, in case in the high pressure, the bony defect is never a big one. The meninges can be sealed with a cobbletter only. Otherwise, if there is a big defect, you have to push the fat in and out to completely clog the defect three-dimensionally. The first layer is fat. Then the vascularized tissue, that is the beauty, to bring in ready-made vascularity to prevent infection. to prevent any raw area. The skull base area is already sealed. It is going to seal primarily, not by secondary healing, by secondary intention. It is primary healing because the ready-made mucosa is there with the vascularity. It is already sealed. So there is no question of infection over there. And at the end of the day, looking at the long run, we have seen all sinuses at the end of the surgery open. Positively, we have identified that rather than assuming. So all sinuses remained open, so there is no question of secondary sinusitis at the same time. And now this seal, once gets matured, you can be almost certainly be sure that the CSF is not going to come from this side. Because it is not the puncture sealing, it is the skull base reconstruction. Multi-layer skull base reconstruction. Any questions?
Any question from the audience?
Yes, we can continue before the next session. Any
Suppose
question,
there
any
is a-
suggestion?
Suppose there is a big bony defect. Obvious bony defect.
उधर ना माइक देना इधर इधर का ऑडियो चालू कर दो
Hello.
मैं कुछ बोलूंगा उसके बाद
Hello. Hello. So suppose there is a big obvious bony
volume
defect also.
हेलो इधर का वॉल्यूम लाओ ना जस्ट अ मिनट सर
एक मिनट पचौरी साहब हेलो डॉक्टर पचौरी
इधर का वॉल्यूम बढ़ाओ ना
इधर का वॉल्यूम बढ़ाओ बेटा
Yes, sir,
डॉक्टर
yes,
पचौरी
sir.
जैसा कि आप जानते हो कि सतीश भाई को क्रिकेट खेलने का बहुत शौक है
अच्छा
तो इस बार आप तो जानते हो मतलब क्रिकेट में चापी कराते हो ना उनके सारे
यस यस यस
तो आपने देखा सतीश भाई के पीछे जो है कि स्क्रीन लगी हुई है
यस देख लिया
ये
हमने।
उसी क्रिकेट के अंदाज में लगी हुई है ताकि ये इन्हें भी यहाँ पर एरिना की फीलिंग आए और ये आपके सवालों के जवाब जो हैं वो एरिना में बैठ कर दें अब आप पूछिए अपना सवाल
Yes, yes. Any questions?
Any questions?
Hello. Suppose Dr. Satish.
Yes, sir.
Suppose there is a big obvious bony defect also.
Yes.
It is clearly seen.
Yes.
Then how? Yes. Then how to deal?
I would reconstruct that length of the bony defect three-dimensionally by insinuating the fat inside and out and completely clog it. The part of the flap will the fat will go intracranial. Part will completely tightly seal the defect and will pull it out until it is completely plugged. So that gives a three-dimensional sealing of the bony defect and then cover with a vascularized flap.
So do you advise post-operative Diamox to the patient?
Not really. Let me tell you, Diamox is not more than a placebo. And sometimes it starts new problems. It invites problem because it leads to potassium loss and patient develops funny symptoms of hypopotassiemia, hypokalemia. So, and see, the role of Diamox is to reduce the water pressure above to a minimal level. It is not everything. If you really want to reduce it or make it a significant one, give thiazides, diuretics. Diamox is something just like a placebo. It can
So
give
this
you
is
feel good that Diamox is working, but it actually doesn't work.
So this is Dr. Yashvi sir from Bhopal.
Yes, sir.
So will you when do you advise lumbar drains, sir? In this pressure leaks, would you advise
Yeah,
lumbar
in,
drains?
in such, no way. I already mentioned in the beginning, if I have a big leak, big defect, and no vascularized tissue available in the vicinity due to previous septal surgery, previous whatever surgery, and I am falling short of any vascularized tissue, definitely I will use the lumbar drain. With this kind of a defect and a good vascularized tissue all the way, there is no question of whatsoever the high pressure is not going to need any lumbar drain or anything. Yes, if I have a post-radiation situation where I can't expect that much good healing, if I have a multiple revision surgery where I don't want to take any further chance, in those situations I can think of a lumbar drain, not always. In a regular situation with this kind of a vascularized flap, even if I had a centimeter big defect With this kind of a vascularized flap, I would not use lumbar drain. In a big defect, that too close to a larger, cistern, like in the clival cistern, definitely I would use lumbar drain because the pressure there is directly high close to the cistern. But in such a regular situation, when you have a good vascularized flap, you don't need lumbar drain.
And sir, what about post-operative olfaction? Do you
Ipsilateral olfaction is always lost once you deal with the cribriform plate.
yes.
It is obvious.
Sir, what's your take on Duragen, sir? Neurosurgeons
Duragen,
usually use a lot.
Yes, Duragen is a artificial, dural tissue to enhance dural repair. So we use in a combined approach surgeries like when we remove large areas of bony skull base in a combined approach, bifrontal from above and endoscopic from below, like in major tumors, olfactory neuroblastoma, and you are left with centimeters big defect. In those cases, we place the Duragen above the dura to enhance the reconstruction of the dura. It's an artificial material. It can really help and help regenerate the dura, but not in these situations.
So what is your post-operative care schedule? When do you remove the pack?
Just
do you
for-
advise nasal douching? When do you do suction cleaning?
Yes, the post-operative picture
and-
now
and
after
one
the
more- and one more
vascularized
question,
flap is all simple. Just remove the pack after 4 to 5 days and everything is, in place, remain till that and mature. And then we start the saline sprays very next day after 4 or 5 days. Give some broad spectrum antibiotic for the raw areas to prevent secondary infection in the septum and in the sinuses. That's it. Like any other regular surgery you can deal with.
When do you-
No
when do you
Dimox,
advocate
no
suction cleaning?
restrictions.
When do you advocate suction cleaning?
After, say, in the second follow-up, 4 or 5 days after remove the pack, then we call the patient after 7 days. So it's almost 10 to 12 days after we can do a suction cleaning to remove the clots or remove the debris or whatever in the nasal cavity or crusting, minimal
My second
crusting.
question pertains to lumbar drainage. There are some patients who tolerate lumbar drainage and evacuation of fluid very well, but some of them have intense headache. How do you manage that?
Yeah,
sir?
so that is because of the over drainage. See, lumbar drainage is a tricky situation. The one who inserts the lumbar drain has to be very experienced because it's a blind procedure by and large, and it works on the feel that how deep the needle is going to go rightly in the place, number one. Number two, the amount of fluid you drain. I mentioned in the beginning, almost 150 ml of CSF is formed every day. So, we drain 5 ml per hour on an average, not more than that. If you drain more than that, if you overdrain, obviously it is going to give a negative pressure headache. So, never overdrain.
What is the total volume you would recommend during daily drainage?
Pardon?
What is the total volume that can be safely drained during a day?
What is the?
Is it a
How much
total
volume?
of CSF? Yeah.
5 ml per hour. We give a
continuous drainage for 24 hours.
Yeah, we'll leave it for 4 or 5 days once you need, even 7 days. So there is a control pressure drainage system available by means of which automatically 5 ml hour can be drained.
Okay.
Satish, there is a question. If there is any pre-operative inflammatory sinus disease,
Yeah.
what should be the protocol for pre-operative preparation?
Just give prophylactic antibiotic, doesn't make any difference. See, sinusitis is inflammatory disease. Once you use a vascularized flap, nothing prohibits you from doing a CSF leak repair. We even do in a situation of pen sinusitis as well, because that is then more required to prevent infection ascending up. When there is already infection in the vicinity, you are giving time, if you are not doing, for the infection to spread up. That is a more demanding situation to do it fast. So there is no concept that the sinusitis prevents you from doing a CSF leak repair at that time. It is more demanding, it is more required.
Okay. So what is the
In
next?
patients with a suspected high pressure, sometimes we know the patient has a pathology about leading to high pressure. The question is how to establish the high pressure. That is the biggest question. You know, pre-operatively when the pressure is already leaking, there is active leak. It is not allowing the pressure to build. So even if you put a lumbar needle to manage or gauge the high pressure, it is never going to give you correct picture because it is already leaking. So the correct time to ascertain the high pressure is seal the defect. Always seal the defect in normal pressure situation. Never ever put any lumbar drain or anything before or shunt or anything before, because then you are creating a hypopressure situation and sealing, and that seal will not be an adequate one. So always operate in a normal pressure situation without putting lumbar drain or shunt. Number two, if you really want to gauge the pressure, seal the defect, allow the fluid dynamics to come back to normal in next 24 hours. I said the 3 times a day the entire volume of the CSF circulates. Almost 500 ml of CSF is produced every day and the volume is 150. So 3 times it circulates in a day. So seal the defect first, allow it to circulate multiple times to establish a normal pressure, and then if you really want to gauge the pressure, put a needle after 24 hours to get the actual pressure. It is always a misbelief that you are gauging the pressure during leak. That cannot give you correct pressure. So if you really want to gauge the pressure, after 24 hours of sealing in the normal pressure situation, that is ideal.